A 62 years old female came with complaints of swelling in the right breast, diagnosed as CA right breast, and for which she was undergone 8 cycles of neoadjuvant chemotherapy, now planned for right modified radical mastectomy. Sir. Patient had
Okay.
no known comorbidities in the past history, no history of similar illness in the family. And obstetric history attained menarche at 14 years and menopause at 42 years. She had 5 normal vaginal deliveries, all were uneventful. Adequate breastfeeding done for all children. Sir.
Okay. Now, what are the challenges in this case?
So since patient has undergone treatment of neoadjuvant chemotherapy, uh, cardiotox issues, sir. Cardiac issues, difficult IV line, intravenous lines, risk of nephrotoxicity. Sir.
Okay. What are the drugs that she was given? Any idea? Did you ask about that?
Yes, sir.
Aware?
Yes, sir. Yes, sir. 1 cycle of paclitaxel and pembrolizumab, sir. 3 cycles of paclitaxel, pembrolizumab, and cyclophosphamide, sir.
Okay. Any rubicin drugs, doxorubicin, edirubicin?
Yes, sir. Next 4 cycles, doxorubicin was given.
Yeah, okay. So, do you have any idea about the anti-cancerous drugs, how they are classified and what are their effects on the various systems? How do you classify the anti-cancerous drugs given to the patient? How are they classified based on their mode of action?
Vinca alkalides, such as vincristin and
That is
vinblast.
the chemical nature. Vinca alkaloid is a chemical nature of the drug, but they are more classified based on the mechanism of action, how they act, how they prevent the cancer cells multiplication, anti-metabolites, anti-DNA drugs. I will not read all that. There is a good article which shows how to classify. BJ article is there. Please go through that and read all about those drugs. And most of them are preventing the multiplication of the cancer cells by affecting the DNA. So topoisomerase inhibitors are there, and DNA pyramids, the blocking the synthesis of DNA, messenger RNA blocking. This is the main mechanism by which you prevent the multiplication of the cells, because the nuclear regeneration or messenger RNA with newer DNA formation is the main mechanism by which all the cells multiply. Okay, so the aim is to attack that. But when you do that, it will not only affect the cancer cells, but it may affect the normal cells also. That is the problem with your chemotherapeutic agent. That is why patients develop loss of hair like alopecia, they go in for nutritional problem, they go in for nausea and vomiting. And so all the side effects are because the normal cells also are affected to some extent. Okay? So that is why nowadays they are trying to selectively attack only the cancerous cells, leaving the normal cells intact so that the patient does not suffer from all the side effects. Okay? And each and every drug has got a peculiar action on various systems, especially cardiovascular system. It can produce diastolic dysfunction, it can produce arrhythmias, it can produce even cardiomyopathy. The doxorubicin is very, very notorious for producing cardiomyopathy and congestive failure. One of my UG classmates' friend who was treated, friend's wife who was treated for CA breast, within 3 months of treatment with doxorubicin, she went in for acute congestive failure because of cardiomyopathy and passed away. So that much of bad effects can be produced, and it can some drugs produce fibrosis in the lung. And some of them affect the cisplatinum group of drugs affect the kidney function. they cause elevation of urea and creatinine and affect the renal function. Some of them affect the nervous system. So all the systems in the body can be affected by different groups of drugs. So it is important that you must know whether the patient has had any of these effects, especially if they have given therapy. And so, how do you classify the chemotherapy treatment? You said about neoadjuvant therapy. What are the other types of therapy?
Neoadjuvant therapy, adjuvant chemotherapy, and palliative chemotherapy, sir.
Palliative chemotherapy. Very good. When do you resort to
Neoadjuvant,
palliative chemotherapy?
sir, in terminal stages to improve the quality of life.
Yes, patients who are not fit for surgery or other treatment, we, are advanced stage 3, stage 4 cases where complete elimination and cure is not possible, you go for palliative therapy. Okay, very good. Right now, for this lady who is posted for modified radical mastectomy, how are you going to give anesthesia?
So first I will add all the monitors to the patient, all the standard monitors, sir. And I will avoid
You want to
IV line
evaluate
and
her for so always in the exam, if they ask you how will you manage, don't jump immediately to the management. First, you make sure that you do a pre-operative evaluation of all the important systems like cardiovascular system, respiratory system, to rule out any involvement. You should go to the neoadjuvant therapy, chemotherapy. That answer you should first say and then plan your start telling your plan of anesthesia. Okay.
okay, sir.
So you can do the basic investigations, then you assess the various system function, and then only you must, because this patient, if he has been having severe vomiting and nutritionally she is very poor and cachectic, do you think it is advisable to go ahead and do the surgery without improving that?
No, sir.
So you must first to
Should
say,
be
I will evaluate and then do the basic minimum investigations, make sure that the cardiovascular respiratory functions are normal, and then you plan for your anesthetic technique. Right. Let us say you have done that and you have done the risk stratification also. What is your anesthetic plan?
sir, I will plan for general anesthesia with endotracheal intubation, sir.
Intubation. Okay. So that
I
is
will put the patient. I will put the patient on table with standard anesthesia monitoring. I will put IV line, intravenous line, and BP cuff on the opposite side, sir.
Hmm. Hmm.
Pre-medications, injection glycopyrrolate,
Hmm.
injection midazolam, injection glycopyrrolate 0.2 mg, injection glycopyrrolate 1 mg, and fentanyl 2 mg per kg IV I will give for pre-medication.
Okay.
For
So the
adequate
standard method of general anesthesia you want to use. Okay.
yes,
Any other technique you want to add for pain relief intraoperatively and postoperatively?
so
Apart
there
from the conventional general anesthesia you give, do you
interfacial
want to
plain
add
blocks we can give.
interfacial plain blocks?
Thoracic
Okay.
epidural we
Thoracic
can give.
epidural.
Uh, paravertebral blocks, sir. PEC 1, PEC 2
Paravertebral block.
blocks, sir.
Okay.
Serratus anterior plain blocks, sir.
Okay.
Then
What is the interaction between the anesthetic agents and the cancer cells? Which are all the drugs which are safer to prevent rapid progress of cancer cells? Which are all the drugs which are safer to use, which will decrease the rapid progress of the cancer or multiplication of the cancer cells? What is the
local
effect of
anesthetics,
propofol on cancer cells? What is the effect of ketamine? What is the effect of local anesthetic agents? What is the effect of various volatile anesthetic agents that we use in cancer cells?
so propofol has an anti-cancer effect, sir.
Very good.
Low dose
Ketamine?
ketamine causes immunosuppression, which can lead to cancer recurrence, sir.
Okay. Local anesthetic agent?
Local anesthetics have an anti-proliferative action and cytotoxic effects on cancer cells, sir.
Very
And
good.
volatile anesthetics will cause immune modulation and potentially increase the
Risk
ability
of
of tumor
recurrence.
metastasis.
Very good. Excellent. Okay. So this is a very basic knowledge and basic question they may ask you. So better to avoid inhalation agents as much as possible, but you can use local infiltration. Propofol are very safe to use in cancer patients for maintaining general anesthesia. So intravenous infusion of Tiva with propofol and local anesthetic agents is recommended to avoid any recurrence or spread of cancer cells in the post anesthetic period. Okay, so this is the technique that you have to use in this. Supposing this patient has got any comorbidity like bronchial asthma or hypertension, you said she does not have any comorbidity. But supposing there is a comorbidity, then how do you manage that? For example, if the patient has a bronchial asthma and hypertension as a comorbidity, what precautions you will take? Because the
For bronch,
question that was sent to me by Dr. Kamachi was that patient posted for CA breast surgery with the comorbidities. So I presume that the comorbidities may be bronchial asthma and hypertension. These two there are there in this patient. How we manage it?
from history, I will ask for the recent
Hmm.
exacerbations
Hmm.
and whether patient is on
First of all, the duration of all the comorbidities. That is the first starting point. How long they have been suffering, what are all the treatment that they have been taking, what is the control of that disease process, what are the current drugs that they are using, which one can be continued or which one has to be stopped. So that is the point that you have to keep in if there is a comorbidity present. So if a patient is a known asthmatic, what questions you would like to ask?
so on what medications he is using for the
First of all, assess whether it is a mild, moderate, or severe. In all diseases, we must always assess whether the patient has a mild asthma or a moderate asthma or a severe asthma. How to assess that? What questions you can ask them to assess whether it is a mild asthma or a moderate asthma or a severe asthma?
by doing
The frequency of
pulmonary function
attacks,
test as well.
especially in the night. Pulmonary function test எல்லாம் போக வேண்டாம். You can just ask clinical history. Supposing patient says I get a wheezing only once in 3 months or 4 months, then I take one puff of salbutamol or two puffs of salbutamol, I am all right. Is it a mild case or a moderate, severe case?
Mild case,
Huh?
mild case.
Very mild case. Okay. On the contrary, another patient says I get a wheezing attack every week and I have to take some oral tablets or then I puff also. Then it becomes a moderate case. Another patient says I have to take medications every day, otherwise I'll get a wheezing. That means it's a case of severe asthma. And also ask for any uh, supplementation with steroids other than the oral, inhaled steroids, whether patient also takes oral steroids, which indicates another severe degree of asthma. Okay. So like that you have to assess the severity and then control the asthma and always preferably give them a inhaled beta 2 agonist before bringing them to theater if you are planning GA, and take all precautions to suppress the reactive airway by spraying the vocal cord with local anesthetic, intravenously in the vein, and all these things should be followed. Okay? So that's how we manage the bronchial asthma. Similarly, hypertension. How do you manage the hypertension? What are the common drugs that are given for treating hypertension, which are of importance as an anesthesiologist?
Angiotensin converting enzyme inhibitor and angiotensin receptor blockers.
That you have to stop
That
or
we have to
continue.
stop, sir. Stop, sir.
Stop. Very good.
Yes,
Other drugs you can continue. And
yes, sir.
intraoperatively,
Beta
what
blockers.
precautions you have to take in a hypertensive patient?
Uh, to avoid intubation stress response.
Very good.
To blunt the intubation stress response by giving intravenous lignocaine or beta blockers such as esmolol, metoprolol,
Very good.
and IV lignocaine we can use, and laryngotracheal topical anesthesia we can use during intubation.
Very good. What is alpine anesthesia?
Increase and decrease in high blood pressure during anesthesia.
Decrease?
Drastic increase and decrease of blood pressure during anesthesia, which will
Excellent.
cause should affect the
Right.
central nervous system, leading to
Yes.
cerebral ischemia.
Excellent. So there should not be very much of fluctuation. Suddenly the BP going to 210 by 110, then coming to 100 by 70, then again going to 180, 90. So if this sort of fluctuation occurs, that is called alpine anesthesia, similar to the Alps mountains, where you go for skiing. So like that, if your chart shows up and down swings in the BP, it is called alpine anesthesia. So that should not be the way you manage a hypertensive patient. It should be a stabilized, same, more or less same recording at a normal level of say maximum 140, 100 is the ideal to maintain intraoperatively, even if the patient is a known hypertensive. You can use all good analgesic agents and supplemental multimodal analgesia with regional techniques so that you can maintain the blood pressure at the same level without much of fluctuation or severe increases, which are very important in hypertensive patients. Okay. So again, I'll just try to show you